Hallux valgus and high heels. Hallux valgus is a greater than 15-degree angular deviation of the hallux with respect to the first metatarsal bone towards the lesser toes, measured by the angle formed by the bisection of the first and second metatarsals. As seen in the image, the point where the two lines meet create an angle greater than 15 degrees. The condition leads to painful motion of the joint and difficulty wearing shoes. It also impairs the gait pattern, increasing the risk of falls. Risk factors include a long first metatarsal and metatarsal head shape, rounded due to genetics, pes planus and a mobile first ray, creating instability, possibly high heel wearing, BMI greater than 30 in women and 25 to 29.9 in men, muscle imbalance, footwear, and abducted first ray. These risk factors were comprised from cross-sectional studies, so causality is not assumed, but this does highlight important factors to monitor in assessment and management. It is more likely that many of these factors contribute to the development of hallux valgus than one alone. The pathogenesis of hallux valgus is not well known, but one proposed theory explained by Michaud states that the flexor hallucis longus and flexor hallucis brevis create plantarflexion of the MTPJ and IPJ to resist dorsiflexion during late stance. Prolonged pronation of the subtalar joint and joints of the midfoot increase the ground reaction force beneath the metatarsal head, leading to dorsiflexion and inversion of the first metatarsal. The first metatarsal is subsequently subluxed on the first hallux. If the hallux cannot remain in a fixed position, adductor hallucis contraction will cause lateral deviation of the hallux. It has been considered that ill-fitting footwear such as high heels with a small toe box can exacerbate the problem by keeping the hallux in an abducted position. The higher the heel, the more the foot slides in the shoe and the greater pressure from body weight that gets shifted to the inside border of the foot. If wearing high heels does increase the pressure under the metatarsal head, this could continue the pathogenesis to hallux valgus. Epidemiology. Prevalence of hallux valgus in the general population. A systematic review of meta-analysis found that the estimated occurrence of hallux valgus was 23% in people aged 18 to 65 years and 35.7% in elderly people over 65 years. Prevalence clearly increased with age and was higher in females, 30% compared to males of 13%. This study used a total of 78 papers reporting 76 surveys found on electronic databases. For our PICO question, our population or problem was older women. Our intervention was high heels as a risk factor. Our comparison was no high heels, and the outcome was hallux valgus. The question we have asked is, in a population of older women, does a history of wearing high heels compared to those who do not wear high heels increase the risk of getting hallux valgus? It is theorized that the risk factor of high heels leads to the formation of hallux valgus. As described in the men's study, this occurs through two features of the footwear. The first risk factor of the high heel was the shoe being too narrow for an individual's foot, where the width of the shoe was smaller than the width of the foot itself. This will force the toes to adopt the confined area of the toe box of the shoe, and therefore cause a lateral deviation of the hallux. The study showed that those with the greatest difference between foot width and shoe width were more likely to suffer from foot pain, which suggests a relationship between foot problems such as hallux valgus and incorrectly fitting footwear. The second risk factor involves wearing shoes with a heel height greater than 25 millimeters. The mechanism through which heel height is theorized to act to cause on hallux valgus is not as apparent as it is with narrow shoes or ill-fitting footwear. However, men's does show previous studies where it is thought to contribute to the development of foot problems by increasing the pressure of the metatarsal heads, which in turn leads to abnormal function of the first metatarsophalangeal joint during gait. Alternatively, another previous study in men's has shown that there is a medial shift of pressure under the foot when shoes greater than 25 mm height are worn, which would likely increase the ground reaction force under the first MTPJ. This suggests that heel elevation may cause the person to roll off the medial aspect of the hallux when walking rather than pushing off directly forwards. Menz et al. Conducted the study. Footwear footwear characteristics and foot problems in older people to examine the relationship between footwear characteristics and the prevalence of common forefoot problems in older people. The study performed by Menz et al. Was a retrospective cohort study, as the participants already have a known disease or outcome such as hallux valgus, corn, and callus before the study was conducted. The researchers aimed to find a link cause between the participants using surveys and questionnaires. Therefore, the level of this study based on NHMRC etiology is 3-2. The main results found by Menz are 27% participants were diagnosed with hallux valgus in this study due to the ill-fitting footwear based on the table below. Furthermore, the second table explains that inadequate width of indoor shoes and inadequate width and area of outdoor shoes significantly cause hallux valgus with a P of less than 0.01. In addition, 26 women, 22%, wore outdoor shoes with a heel elevation greater than 25 millimeters, which is a significant cause of hallux valgus with a P of less than 0.05. Recommendation: we concluded the grade of this study is moderate because it is a high quality retrospective cohort study showing the measurement, high heels, to be related to the injury hallux valgus. Therefore, we should include the measurement, which is the high heels, in the player screening. Nguyen et al. Conducted the study factors associated with hallux valgus in a population-based study of older women and men to determine possible risk factors for hallux valgus. Evidence obtained from comparative studies with historical control, 2 or more single-arm studies, or interrupted time series without a parallel control group. This is when patients with a certain outcome and an appropriate group of control without the outcome of disease are selected, usually with careful consideration of appropriate choices of controls and matching, and then information is obtained on whether the subjects have been exposed to the factor under investigation. Therefore, on the NHMRC scale, it is a level 2-3. The women who usually wore high heel shoes during ages 20 to 64 years compared to those who did not had an increased likelihood of hallux valgus. The study conducted by Nguyen in 2010 indicates a case control group where there is a limited causality, whereas more association showing that there is a connection between plantar heel pain wearing high heels. Women who usually wore high-heeled shoes during ages 20 to 64 years compared to those who did not had an increased likelihood of hallux valgus. This is demonstrated in the figure, where the duration of past high heel use as our X value and the hallux valgus risk ratio as the Y value. The figure illustrates that high-heeled shoes as their usual shoe type between 20 to 64 years of age were 20% increased likelihood of having hallux valgus compared with women who did not report wearing high heels as their usual shoe type between ages of 20 and 64, where the P is 0.04. Based on all clinicians, we have interpreted this study as a moderate grade study, as being a case control study group. The recommendation of consistent findings among multiple studies, or one high quality study showing the measurement to be related to the injury, to include the measurement, which is high heels, in the player screening. Both the Menz and Nguyen studies conducted show a suggested relationship between wearing high heels and the development of hallux valgus. Further studies do need to be conducted, such as 2 or more high-quality cohort studies, to show a stronger relationship between the two, to be able to prove causality between the risk factor and the condition.